Thanks everyone for joining us for the webinar for the 2016 aHUS Global Poll results with Dr. Christoph Licht and Linda Burke, who we're very happy to have here today. Just a quick thank you to both Linda and Dr. Licht, as well as Len from aHUS UK for helping to get this webinar going today. So my name is Rob, and I'm the Online Community Manager with the European Organization for Rare Diseases, EURORDIS, on Rare Connect. And in today's webinar, if you have questions, you can type them in the chat box, and we'll try to get to them at the end. I'd like to encourage you, if you haven't already, to register for the Atypical HUS community on Rare Connect. The website is available in 6 languages with human translation. It was started in partnership in 2011 with aHUS patient groups, and I'm happy to say the number of patient groups for aHUS has only increased since then, as well as the start of the aHUS Alliance a few years ago. And I think the formation and the support from some of those for some of those patient groups to start were forged by connections and conversations that were made through the community on Rare Connect over the last now 5.5 years. The community has over 40 stories translated across the 6 languages, allowing families and individuals to share experiences no matter where they are living in the world. It also contains webinars like this one we did on the first aHUS poll with Dr. Goodchip from Newcastle, as well as videos from conferences. And the webinar recording of this webinar will also be put there on the community. Finally, the Learn section contains information on the disease and further links to the patient groups who are partners and really the bedrock of these communities and of the aHUS community. And our member section, sorry, that's that. And our member section now has a map so that people can get in touch with others nearby. There's about 312 members on the map. So please take a moment to save the community link where you can find the webinar video and the slides. And I just wanted to have that little introduction about the aHUS community and now bring it over to Linda, a volunteer with the Atypical HUS Foundation, who's going to tell us more about the 2016 poll and also.
And thanks everyone for joining us today for this webinar dealing with the Atypical HUS Global Poll, which was started on Rare Disease Day 2016 and ran through April 15th. This webinar will go over some of those results and provide you with some background information as well. My role as a member of the Atypical HUS Foundation in America is a volunteer, and I serve in that same capacity as an American representative to the international group of Atypical HUS patient organizations, the aHUS Alliance. Currently, there are about 15 different nations in the Atypical HUS Alliance. When we think of patients being ill, diagnosed with a chronic condition or a rare disease, the first thought that people think of is what's at the heart, which is patients and doctors working together with a team in a coordinated care managed plan to bring a positive patient outcome. It's a little bit different in cases where rare disease patients are involved, because this diagram would actually be much larger. Because when you look at the doctors, it's not just a general practice physician. We have in the atypical HUS arena oncologists, hematologists, nephrologists, but also immunologists. We have wonderful nurse navigators and case managers to help as well. There are support systems in place for the social and economic hardships that deal with people who are challenged by a rare disease. So in fact, in rare disease, the communications flow is actually quite different. And at the heart of that are rare disease patient organizations. Some are very large, which would be national ones that handle all of 5,000 to 7,000 different rare diseases, according to the World Health Organization. There are smaller regional patient organizations that are country specific. Some are language specific. Others deal just with kidneys, still others with rare genetic conditions. But if you look, every one of these stakeholders, whether it's researchers, families, medical personnel, the wonderful caregivers who make everything possible and keep everything running, friends, all these things support patients, and they're all involved in collaborating, in partnership, and most importantly, in sharing information. Because at the heart of what the atypical HUS community is concerned with are patient organizations that bring people, information, and resources together. It's the patient voice that needs to shine through in patient care. The Atypical HUS Foundation in America was an early adopter of this, but the actual Atypical HUS Alliance was formed a couple of years ago with 6 founding nations, and now has grown to be approximately 15 different patient groups around the world that unite together with common goals. The first thing that they are concerned with is making sure that all patients and patient groups have access to information, share that information, and work together to provide a brighter future for Atypical HUS Foundation, Atypical HUS patients. We assist each nation with their global initiatives, but we want to focus on what is important in each nation. Each nation has different needs, each nation has different concerns, and so the aHUS Alliance supports them. Part of that is providing a global patient voice, and that's something that the 2006 global poll helped with. So our goal as an alliance is to provide interactions among all people in the communication network that will be involved with bringing together different aspects of aHUS treatment and research and care. Our motto is good will come together. The alliance is important because atypical HUS as a disease doesn't have any borders. It doesn't recognize differences in cultures, in languages. It affects patients of all ages. So when the alliance was created in 2013, we wanted to become engaged as a group in some key issues. One of our first initiatives was working with Rare Disease Day and promoting atypical HUS awareness around the world. Last year, the Alliance's key goal was the creation of an aHUS Awareness Day on September 15th, and we will be doing that again this year. It's very difficult for small patient organizations to attend professional conferences and regional meetings because funding is an issue for any small rare disease group. So we do try to develop different assets and resources so that we have a shared pool of robust and accurate information about the disease. And our goal is to connect, inform, and collaborate among all the stakeholders. It's very difficult with anyone with a rare disease. The World Health Organization says there are between 5,000 and 8,000 different rare diseases. And in that report, it mentioned the variability in how rare diseases are defined. In America, it defines rare diseases with a different set of parameters than it does in the European Union. And so when we look at the challenges of being diagnosed with a rare disease, if you're not thinking about a rare disease, it's very difficult to see the forest for the trees. If you look to the left of this, you can see that there are a group of trees, and in the foreground, there is a tree with a single red leaf. And that single tree in the foreground would represent all rare diseases among the different types of disease that affect mankind. And that single red leaf is how difficult it would be to spot a case of atypical HUS. The 2010 report out of Iowa mentioned that in America, they estimated there to be almost 2 people out of 1 million with atypical HUS. Given the number of people in the US, that would be talking about less than 650 patients in America. But with a global population of 7,332,000,000. The estimate worldwide using that figure would be less than 15,000 people worldwide with atypical HUS. So it's a very difficult disease to diagnose, and it's only one of many complement-mediated kidney diseases. For an overview of the global poll, patients and caregivers worldwide were asked to participate. There were 233 respondents from 23 countries. They responded in 6 different languages: English, Spanish, French, Russian, Italian, and Japanese. As mentioned, we launched on Rare Disease Day. And as we rolled out new languages, we closed the poll on April 15th. So global poll actually is providing insights into the atypical HUS experience. It's providing an authentic patient voice that identifies niche issues and needs worldwide on areas such as the speed of diagnosis, treatment options, and medical care options, which vary greatly from country to country. These poll data will be available through the Alliance after the webinar. Since we are a volunteer team, we are going to be rolling these out in stages, so please do connect with us. Our website is at the bottom, aHUS Alliance action.org, which is where the information will be posted. We did go through and we did reach out on social media. All nations were involved with every area of the global poll. Patients and patient questions, social media commentary, trends that appeared, information from the literature, conversations with industry, conversations with clinical trial people. All of these fed into the survey questions that were created. After a subcommittee of various nations composed and constructed the survey poll, all nations were invited to participate. And you can see some of the results that were here. It was pretty evenly split between adult patients who responded. A slightly smaller number of pediatric caregivers participated in the poll. Almost 2/3 of the poll respondents were female. The most common age that they mentioned for initial onset of the HUS patient were young adults, and the second most common group were children under the age of 3. An amazing 84% either have received genetic testing results or are awaiting them currently. The poll results were highest from America, 43% of respondents. The UK, there were 18% of poll respondents from the UK, with 11% for Canada. The other 20 nations that were responding accounted for less than 10% of the survey responses in the remaining 20 nations. Interestingly, where do people get their aHUS information? A surprising 37% said that they rely on their aHUS patient organizations within their nation or the aHUS Alliance to receive that information. 17% received that information from the doctor, and 26% received information about atypical HUS by looking online. So that's important to keep in mind when looking at the value of patient organizations worldwide. At this point, I'd like to hand it over back to Dr. Licht and to Rob, and to just look forward to hearing what Dr. Licht has to say. And we're going to be also giving a brief wrap up at the end of this talk to give you a little bit more information about the Alliance and the poll results. Thank you.
Thanks,
very
Linda.
much. All right, can you hear me? Perfect. So, my name is Christoph Licht, and it's a distinct honor and pleasure for me to being invited to joining you on this aHUS Rare Connect webinar today. What I'm going to do is I'm going to introduce briefly what I'm doing, and then I will briefly comment on the results of this global poll that Linda was already sharing some of the results with you. And then I will give you some background with a few slides that I've prepared on Atypical HUS. I called it Updates 2016. And I would really welcome active participation from all the participant side via questions. I'm happy to be interrupted at any point in time. So I'm a pediatric nephrologist working at the Hospital for Sick Children. My background is German. I have a long-standing interest in complement-mediated diseases, in particular atypical HUS. I'm working both on the clinical side, seeing patients and running a patient registry, and also on the basic science side, trying to understand the mechanisms of atypical HUS in the lab. The registry that another role that I'm playing that might be of interest to you is I'm the current chair of the International aHUS Registry, which is sponsored by Alexion. It should be known to most of you. At the moment, it includes more than 1,000 patients with atypical HUS worldwide, which is a phenomenal resource, and we're actively working as the scientific advisory board to make the best use of this incredible resource of data in form of data mining, evaluations, and preparing manuscripts. So stay tuned on one side. On the other side, work through your doctors or directly to connect with this registry and ask your questions. Since it is not a tool of a company or a small group of scientists, it's your data, and I encourage you to use it as such. With that, I'm coming to my comments on the global poll, and I'll start with the final segment. You may have seen that there were, or you may remember, there were 6 segments. The first 2 were talking about the person filling the registry or the poll. The second about the patient, the third characterizing the patient, the fourth about the treatment, and then the fifth about research involvement, and the sixth, if you want, moving forward questions being important. So at this tail end, this is really your voice, where you are stating what's of your interest, what matters to you. And in the first place, I'm impressed by the fact that many of you are already involved in research or do have an active interest in participating moving forward. So this is something that I'm extremely happy for, and I would encourage you to become really an active member of this research community. I think this is the second comment. The theme is shifting. In the past, we were more used to a pattern where researchers, scientists were, if you want, leading the path, leading the walk by identifying questions and doing the research. I think you have assumed, and I encourage you to continue doing that, a way more active role now in this context, identifying what your questions are, what your needs are, and bringing that to the table. You will direct the direction that research takes in the future even more. With that, the questions that you obviously identified as being important for you as patients or as caregivers refer to, or let's say first, the problems that you identified are the ones that spin around the impact that the disease has on your lives. So it disrupts, the family life. It has an impact on your normal activities, which is probably way more in the forefront of your concerns than it has been in the past for scientists, for researchers, for clinicians. So this is a learning from my side, very much so. Let me go briefly through the questions from the beginning now. I won't spend too much time. The segment on the patient characterization is not really bringing a lot of surprises. We have a clear prevalence of patients of younger age, under the age of 10. There's another peak in the young adults, 20 to young and mid-age adults, 20 to 50. And that is where most of the patients are identified. We have a prevalence on the female side that is known in the literature, so this is not a surprise. I'm very much impressed by the fact, Linda said this already, that a huge number of patients has been genetically tested or is awaiting results. So this has already, this has really changed the field significantly, I would say, that patients are aware of it. Doctors have identified where to send testing to and make use of it. At the same time, the turnaround, which is another question, is poor. The average or the predominant wait time is 1 to 3 months, which is way too long in my mind, and we have to work as a community to shorten that wait time to have the results back at the clinical front line. The findings of this genetic testing are pretty much in keeping with what we know. Factor H mutations are the most prominent genetic mutation causing atypical HUS. But I would also like to highlight that 7% of patients are identified with multiple hits. So there's a concept, and I'll come back to that in my presentation, that patients can have more than one condition. And it might be important to realize that, since one alone may not be enough to tip a patient, an individual, over to precipitate a disease, but 2 or 3 increase this risk significantly. Another group of results, and unfortunately that scores second highest, is the one with inconclusive results, meaning that you find something but you don't know how to interpret those results. This is another huge area of, if you want, opportunity to improve. And this is now talking to myself as a representative of the medical community. We have to work harder to learn more about the interpretation of genetic findings in terms of their causal role and their predictive value for patients. Another summarizing finding over a number of questions is that, or observation if you want, is that while a good number of patients had to be dialyzed in the beginning in the first phase of the disease, only about 1/4 to 1/3 of the patients really stay on in a situation where they require ongoing renal replacement therapy, like dialysis, or progress to a situation where a kidney transplant is required. This is identifying, based on this sample of patients, actually a better clinical outcome as compared to what is in many papers published. So I'm not trying to create kind of a disconnect here between research in the literature and the data that we have here in the poll. But what I'm identifying is that we have to learn more, and databases like this global registry will hopefully help to give us more solid information on what to really expect from the outcome of for the outcome of patients. What I again want to highlight is that the question, what is your, the biggest concern, the biggest burden of being a patient in renal failure, is not so much in the first place the medical impact, but it's the burden that is carried on the side of the family life, impact on job, impact on school, disruption of your normal lifestyle. So I think this is, as I said already, but I find it so important to say it again. I think this is another level of question, another level of research that we as a community of scientists have to pay way more attention to, as we have done in the past. Let me briefly, well, and then of course the big complex of treatment. So I'm still impressed, even though we have such a predominant kind of subgroup of patients being included from the US, from Canada, and from the UK. We still have a high number of patients who have been treated with plasma, which, as you know, in the pre-eculizumab era was the standard of treatment for aHUS patients. So I'm not really sure how to interpret this information or this finding, since on the other side, the majority of patients is eventually commenced on eculizumab. So there's a little bit of a discrepancy that I have a hard time to interpret. It might be that we're talking about plasma treatment for an initial short period of time before patients are then commenced on eculizumab. But this is not really in the results or in the answers. So I have to be careful with the interpretation, but I find it remarkable to have this high peak of plasma treated patients. Access to eculizumab remains a major issue. And the you may have seen those results. It seems relatively benign, if I can use this word, and getting access to eculizumab. If you take the global outcome of this poll, if you break it down and subtract responders from the US and or Canada, you end up with a big problem. And this big problem is price driven, which is clearly identified in the registry. I keep saying registry, in the poll. So you say, obviously, as a community here, you speak out what we all know and what we all, if you want, are struggling with. Access to drug for a high price is an issue, and that is very much impacted by the country background a patient is connected to. I would like to conclude with a final comment on the list of topics that you suggest for research moving forward. I identify two major subgroups, if you want. One subgroup is spinning around treatments, which is tailoring treatments, withdrawal of treatments, and new treatments. This is very obviously on your mind and an important topic, and there's a lot of effort going into this direction, and maybe I can comment on that while I'm presenting my slides in a moment. And then a second one is, or related to the treatment, is the question of withdrawal and understanding remission, which I find a very smart and very important question coming from your side. And then obviously the other complex that I see is spinning around the genetics, the impact of genetic findings for individuals, but also for families. And that kind of closes the loop back to what we have said a couple times. It's great that so many patients already had or will have genetic testing. It's still poor performance in terms of turnover. And there is this problem, remember the results of the genetic testing, second highest scoring finding was we don't know how to interpret the genetic results. So this remains a major topic and a task for us researchers. So with that, I would like to stop commenting on the poll, and would like to share a few slides with you. Linda, can I move on? Okay. All right. Perfect. Rob, please give me a little bit of a warning if I'm going too long. You see how many slides I have. I'll try to be relatively swift. Okay. Thank you. All right. So here is an update on Atypical HUS 2016. I begin with just an illustration of the disease that we're dealing with. This is looking into a histology representation of a kidney where you see clots kind of obstructing blood vessels, but also those round structures which are the glomeruli, like the filtering bodies in our kidneys, which is basically the problem that we run in Atypical HUS. Those clots that obstruct those filter units and give us predominantly a kidney problem, but can affect other organs as well. This slide is meant to give you a feel for what Linda also was referring to, this rare disease issue. The data are shared by a French colleague, and the data are referring to basically a reflection of the individual diagnosis in the background of the French population of currently about 65 million. So what you see in the center is the most prominent, if you want, form of HUS, which is the Shiga toxin mediated form. So that's the hamburger disease, as you know, 100 per year in a population of 65 million. Everybody can do the math based on his or her own country. Different from that, I just leave it with that, the atypical HUS, which is only about 10% of that. So 10 patients in France which develop this disease in a year. And then the others are even more rare. Moving forward, we'll focus on atypical HUS only. Clinically, as you all know, it is characterized by at least two features in the lab, a low hemoglobin count, this hemolytic anemia, and a low platelet count, thrombocytopenia, and then renal failure. But besides those three findings, we have learned, and this is really important, that many other organ systems, if you want really the body head to toe, can be involved. And just one highlight, the GI tract is predominantly affected. So many patients either have at first presentation, at flare-ups, or unrecognized and only identified when actively investigated symptoms in their GI tract in form of abdominal pain, diarrhea, can be even bloody, or other abdominal symptoms which are in the past have not been often not been linked to or connected to the underlying atypical HUS. I want to share this slide here with you, and it's following up on what I said earlier when I was commenting on those poll questions that we have learned over the past years that atypical HUS happens often in a situation where a couple of hits are present. So it's not the one thing that kicks the disease off. It's often a combination of events that make a patient tip over and cross the line of the clinical manifestation. And being a carrier of a mutation or of antibodies predisposes a patient to be at a higher or a lower risk to combine triggers, which can be infections, even mild infections like upper airway infections, to combine them with the genetic background to then result in a constellation that results in the clinical manifestation of atypical HUS. Treatment, the modern form of treatment, which is complement inhibition, is basically can't undo the genetic background. It can't remove the triggers that we are all exposed to, which are often environmental. But it raises the bar so the body is not manifesting the symptoms, even though there are triggering events and there is possibly an underlying genetic component. This slide I click quickly through is to remind us just of the concept of the complement system as this activation cascade. At the top right, you see alternative pathway. That's the starting point, what we think today of atypical HUS, where a system is basically spontaneously active and allows this C3, C5, C5b9 activation cascade to be initiated and to be executed to the final step. And if that cascade is not properly regulated, and this slide here just shows you a couple of examples of how this inactivation or this regulation can happen by cleaving active products of the cascade or by accelerating the natural decay of the components that allow for the progression of the complement activation cascade, or by protection of cells, of tissue against the final product of this activation cascade. If that normal required protection is not in place, then disease happens. And that's exactly what we have in atypical HUS. Defects in those naturally regulating proteins. We call this loss of function. And we know factor H, we know factor I, we know a couple others, MCP and THBD. If those are either absent or mutant, then the cascade progresses faster and there's more of this toxic end product. Antibodies can do a similar trick as in a factor H mutation, or mutations that enhance the function of propelling components of the cascade, like mutations in factor B or C3, would also allow this or push this cascade to be more active and give more of the toxic end product. Altogether, in a similar way, resulting in tissue injury. There is a couple of new genes in the literature which I'm not going to talk about, but I want to mention them. DGKE is one of the more recent publications, and then there is one paper that talks about plasminogen and von Willebrand factor mutations also in atypical HUS patients. Knowing about those mutations, I spoke about that already, is a challenge. Some information seems very clear. Patients present with a very clear-cut phenotype, or research has been done testing the mutation in the lab. So we are pretty confident that a specific mutation causes really a problem. In other situations, we don't have this insight, and we're struggling with the prediction of the impact. But what we can say is that at least one piece of information we can deduct from those genetic findings, which is the expected onset of the disease. So certain mutations come with a higher risk to present earlier in life. Factor H, factor I mutations, and also this DGKE mutation would present really early in life. At the bottom, you see that's a timeline in years, as opposed to MCP mutations or factor H antibodies, which present later in life. We're still talking about childhood, but you see a difference between those mutations and the age of onset. Now, there's another thing we can learn from those mutations. This is not very recent data anymore. It's from 2013. So those patients or the courses of those patients date back a little longer. And what you see here is in those little systems is survival of kidneys. So basically decline of kidney function to a situation where dialysis is needed. And the timeline is months. And every system represents one mutation. And the blue lines represents children, and the red line represents adults. So maybe not stressing too much the detail, but what you can see is that those lines take different slopes. Some red and blue lines go together. For factor H, they rapidly decline, and there's not much of a difference for blue and red, adults and children. But if you go to the last system here, MCP mutations, there's a big difference between the expected outcome in the blue system, which is children, and adults. So to translate that into plain English, if you're an adult with an MCP mutation, your chances to lose your kidney function are dramatically higher than for a child who has a relatively benign course over the years. So that is one way, or already with the two slides that I've shown you in the past few minutes, that's two ways how we can learn and use genetic information to inform ourselves and also predict the course of a patient. I'll skip through this slide. It is really just meant to show in comparison to factor H and MCP and C3, factor B mutations, how the DGKE mutations are presenting clinically a little different. But as I said, I don't want to focus on that today. All right. So all these data predate the time of specific complement blocking treatment. As of 2011, we have access to a monoclonal antibody, which is in a cartoon shown here, and you all know its name, eculizumab, or Soliris as a trade name. It's a antibody, a monoclonal antibody, so it identifies exactly one protein, which is C5, one of those complement cascade proteins, which was originally generated in mice and then adapted to be usable in humans. So we call this humanized. As I said already, it recognizes complement component or protein 5, which is basically the beginning of the terminal steps of the complement activation cascade. if you interrupt the sequence here, you don't generate those toxic products of the end of the complement cascade, but you allow for the function of those apical higher up in the cascade steps and components of the complement cascade, which is actually helpful for us since all these proteins have a function which I'm not going into detail of right now. Using now this antibody in patients has resulted in remarkable results. And I'm showing you here in summary 2 slides combining the observations in about 35 to 40 patients who were treated either with a relatively acute presentation of their disease or a relatively chronic presentation of their disease. And I'm showing you in the top system the recovery of the platelet count or the improvement of the hemolysis. And at the bottom in 3 different figures, if you want, improvement of kidney function. And what you can see is low numbers are bad situations of the patient, higher numbers are in both systems an improvement. You see after starting the treatment, which is the far left of those 2 systems, a rapid and sustained improvement over time, both in the hematological components and in terms of kidney function. And this is true for the second cohort of patients as well. As you can appreciate in the bottom system here, those lines are improving, but they're improving a little less rapidly, which is reflective of the fact that those patients were sicker and had renal impairment for a longer period of time. Now, another point that came up in your global poll was the question of how can we interpret disease activity in a patient and what happens if we discontinue, so treatment duration basically. And the honest answer is we have no final answer to this. We don't know. We have some sort of an understanding that the spread of mutations or the presence of antibodies basically describes a risk profile. You have a spectrum of higher risk and lower risk situations where patients with higher risk mutations would probably be running into problems if they were discontinued from treatment, whereas others might have actually a fair chance to be discontinued and remain stable out of the lower risk category. But we are still not in a position where we can confidently define those risk categories. And that's why it is so hard to, at the moment, guide patients and deal with limited access to treatment as it is the situation in some countries. So this slide here summarizes basically, again, the French experience with discontinuation of eculizumab treatment in atypical HUS patients. And it breaks down the course of the patients based on their underlying gene defect. So at the top, factor H mutations, here MCP, factor I, C3 mutations, or no mutation identified. And I'm just referring to the third column, which says patients who relapsed after discontinuation, the absolute number and the percentage. And what you can see is kind of following the lines of set the risk profile. 5 patients, 55% of the patients with factor H mutations relapsed. only one of the patients with an MCP mutation, only one out of the category where a mutation was not identified. If you just go back to factor H and factor I and MCP, I'm sorry, that is kind of corresponding with the line graphs that I showed you earlier, that predicted the decline of kidney function over time, rapid decline, poor prognosis for the one with factor H mutation, relatively benign course for children, remember children, not adults, with an MCP mutation. So we have some sort of a gestalt of what a risk profile looks like, but we are at the moment trying to consolidate this idea, this feeling with proper research to guide treatment duration discussions in the future with more insight. I think I'm skipping through this here for time and through this here and go to this slide. So one of the big questions is always how to establish the diagnosis of atypical HUS. And this slide here is basically a fair summary of what we currently do in clinical practice and what's probably also the best we can offer. So you start with the appreciation of clinical symptoms: anemia, thrombocytopenia, renal failure. You will have to exclude the top alternatives, which are Shiga-toxin-mediated HUS and ADAMTS13-mediated TTP. So you test for the presence of those toxins or the activity and the activity of this enzyme called ADAMTS13. If you find Shiga-toxin positive, you're dealing with a patient who has the Hamburger disease, no atypical HUS, and you can stop there and treat accordingly. If you have a patient who has obvious biochemical findings identifying a dysfunction of this ADAMTS13 enzyme, the number is less than 10% of activity thereof, the diagnosis is TTP. If both are either negative or the activity of ADAMTS13 higher than 10%, both are excluded, then you're dealing with HUS, which is either driven by an underlying disease. If that is not the case, this is your atypical HUS, and you do genetic testing and test for factor H antibodies, or you have an underlying disease or condition like pregnancy or an infection or something like that, and then you're dealing with a diagnosis that we, at the moment, for lack of a better term, call a TMA spectrum disease, and the jury is still out if or if not genetic testing and the screening for antibodies, factor H antibodies in those patients, with other words, a contribution of complement defects in those patients plays a role. How does that translate in patient management? If you have, this is actually based on a current review article, which is probably a consensus amongst experts worldwide and the best we can offer at the moment. If this breaks down into age groups. So if you deal with a TMA patient in the adult group, you will start management by using plasma exchange and initiate treatment, as I just said, to rule out Shiga-toxin HUS and the ADAMTS13-driven diagnosis. If this ADAMTS13-driven disease is ruled out, you switch plasma to eculizumab treatment, since your most likely diagnosis is atypical HUS. If you identify the ADAMTS13 defect, you continue with the plasma exchange, since that is then the appropriate treatment. If you identify coexisting disease you stop plasma exchange and treat this underlying disease, like an infection. In children, however, the situation is a little different. Of course, you also initiate treatment, diagnostic workup up front. But you don't, according to the most recent standards and recommendations, you should actually try to avoid alternative treatments and just go with supportive care until your diagnostic workup is back. And then based on the results of this diagnostic workup, you either know it is the ADAMTS13 disease resulting in plasma treatment, or it is the Shiga toxin disease, which results in supportive treatment and no specific treatment. But if both are ruled out, you are dealing with a patient with a diagnosis of atypical HUS, and you should, as first-line treatment, use eculizumab. And you would even bypass the wait for the results in a patient who is very sick and would initiate treatment with eculizumab. The same strategy would apply to the scenario or situation where a patient has received a solid organ transplant, like a kidney graft, and develops recurrence of TMA in that graft. Actually, right at the time of receiving this graft or at the time of recurrence. So in both situations, eculizumab would be your first-line treatment. Now, there's one specific condition that I would like to talk for 2 minutes about, and then I have another 2 minutes and we'll be done. It is the antibody-driven atypical HUS. I won't bother you with too much detail, but I want to share with you that the literature is actually not exactly clear on what the best treatment strategy for those patients is. It is recognized that this is an antibody-driven disease, in the end impairing the function of the complement system and basically resulting in consequences very similar to a factor H mutation, but it is driven by factor H antibodies. So you don't have to, you're not bound exclusively to a complement controlling treatment strategy, but you can address the antibodies and try to remove them or bring them down. And this has been beautifully shown in a cohort of about 160 patients from India, in whom strategies to address antibodies, either by medication, prednisone, cyclophosphamide, rituximab, MMF, or azathioprine, or none of this treatment were used, and the outcomes of those patients with antibody-mediated atypical HUS were compared. And as you can see, patients with plasma exchange and one of those medical treatments versus no treatment had a much better outcome. And a similar benefit was shown when patients after an induction therapy, so treatment at the very beginning, had then also continuous treatment with immunosuppression versus none. And this is actually logical, since the same group also could demonstrate, we can just look at one system here, that high antibody titers, those dots here on the left side, go with, are found at the onset of disease and can be brought down by the treatment, including plasma exchange or immunosuppression. And at the bottom here, you can see that disease activity correlates with the level of those antibody titers. So high titers, high disease activity; low titers, low disease activity or disease remission. So you have a correlation between antibody titers, and you have treatment strategies that bring those antibodies down. And with that, you're not left alone with strategies that block the complement system like eculizumab. And this is basically summarized in this very busy cartoon, which in the end of the day suggests exactly that. In an antibody-driven HUS, you have the chance to use immunosuppression to bring the antibody titer down. And only in the very acute situation you would use eculizumab or another, in the future, another treatment that blocks the complement system. My final, I think it's 3 slides. A new theme in the literature is to use our advanced insights into the effects of complement dysregulation on the inner surface of blood vessels to basically monitor disease activity of patients. That is one of the themes that was in your global poll, and that is one of the themes that I can share with you is very high up on the list of the International Researchers Society or community researchers interested in atypical HUS are striving for strategies to monitor the activity of a patient with atypical HUS. And what this group here from Italy has done was they developed a test system where they use cells that are similar to the cells that you find on the inner surface of blood vessels. And they incubate those cells with serum that they take from patients at various stages of their disease. And if you just focus on those 3 bars at the very left, compared to the white control, they have serum of a patient with acute disease, and then they have serum of a patient in remission. And you see the difference in the height of those bars. So acute disease, high bar, a lot of complement on those cells, and in remission, this goes down. So this illustrates, and this is actually for the first time so nicely shown in a translational approach, that you can really monitor disease activity or illustrate, reflect disease activity in a test system. Now, they use this insight now to apply it to hands-on management of patients. And they do it on several patients. I just show you 2 examples. Here, this is referring to a 7-year-old boy who developed atypical HUS due to factor H mutation at the age of 6 months. And as you can see at the top, the patient had plasma therapy, went on dialysis, eventually needed a kidney transplant since he failed all these treatment strategies and had to be dialyzed since he didn't recover kidney function. And the patient eventually received a kidney transplant with eculizumab based on age and weight, treated according to protocol with 300 milligrams after induction as maintenance then every 2 weeks. At the bottom here, kind of similar to what you just saw, those bars, high bars, a lot of complement activity, lower bars, not so much complement activity. And actually this horizontal bar would show you from which on the height of the vertical bars become clinically significant. So you can see the first bar is high. That is basically just before the kidney was transplanted and before eculizumab was given. And then eculizumab was given according to protocol. You see the bar goes down, but it doesn't go down to below the horizontal one. That's where you want it, to be really safe. And the patient, in fact, had clinical signs of ongoing disease activity, even though he was treated according to protocol. So what they did was they increased the dose from 300 to 600 milligrams. And this is the result. They achieved suppression of complement activity to exactly where they wanted it, below the horizontal bar. And this worked in a second patient in a similar way. This is now a young adult, another male, 36 years, if I correctly remember, also factor H mutation, failed plasma treatment, had to go on dialysis, and then was treated with eculizumab according to adult protocol. Pre-eculizumab treatment, high complement activity as seen on the previous slide. And now this patient achieves with the protocol therapy very good complement suppression. This complement suppression worked so well that the group said maybe we can increase the intervals from 14 days to 3 weeks. They did that and still achieved full complement suppression in their test system. And from then on, they were confident that they could treat this patient with infusions Q3 weeks instead of Q2 weeks. So 2 examples. One example resulted in intensification of the treatment, and another one in a less intense treatment using a modern system of testing disease activity. And to summarize, I think we have heard a little bit about the establishing of a clinical diagnosis of TMA. I have briefly mentioned that there is this theme of TMA or aHUS that can exist along with underlying coexisting diseases. And that translates, of course, into a specific workup to investigate for those parallel underlying diseases as well. If this is not the case, if you don't have a disease that is basically behind the aHUS or the TMA, then you are left with either the Shiga toxin, the TTP, or the atypical HUS diagnosis, and that would warrant the workup that I explained to you, the ADAMTS13 workup, the Shiga toxin workup, or the complement workup. And this is just a very brief nutshell here. Again, I was pleasantly surprised to see that the individuals who are reported in the global poll had access to, in a majority, had access to a very extended workup, including the genetics, which I find a very encouraging outcome. I leave you with this slide here, which is my summary of atypical HUS. It is, if you want, a tug of war. It is a balance of activating and regulating components. If one side takes over, becomes stronger due to the impairment of their power, then the system tips over and something problematic happens, not to the children here, but as you all know, it can be very dramatic for patients. With that, I leave you, and I'm very happy to take questions. Thank you.
Okay, thanks very much, Dr. Licht. Linda, do you want to connect and start us off with a question? Or perhaps I can ask one of the ones from earlier that I recorded while Linda gets...
I think perhaps we should start with the questions that have already been asked.
Great, sounds good. Thanks, Linda. So Zahi was wondering if you had any contacts to pass along to him for his 1-year-old son who was diagnosed with aHUS, and he's having difficulty doing genetic testing in Saudi Arabia. Is that something you could help him with, or would you know any clinicians that could?
Yeah, so I'm happy to help as much as I can. I guess the best would be to get in contact via email.
Okay, sounds good. So I'll work with Zahi to try to have that conversation offline. His other question was, will the vaccination schedule be changed due to aHUS? Could you comment on that?
Right. So the person asking this question is referring to the fact that eculizumab treatment in atypical HUS patients comes with a requirement to be that those patients have to be vaccinated for meningococcal infections in children. The recommendation today is also pneumococcal and HIV infections. The meningococcal treatment is, for the most part, not part of the standard vaccination schedule. So it would be an added vaccination. It's not. I wouldn't refer to it as a change of the vaccination schedule. For this one indication, there wouldn't be a change in the kind of national or international strategy to vaccinate children. But there's a specific need that comes from the consequences of complement blockade via eculizumab in patients receiving this treatment.
Okay, thanks very much. The next question was from Cheryl. Is there any research investigating the continuing experiences of neurological impairments and treatment options post-Soliris or another new treatment option? I'm not sure if maybe this is something you're not even aware of, or...
Right. It's probably two questions, if I may say that. So one question is using the example of neurological involvement to coming back to the topic of extrarenal involvement. And in fact, yes, this is, very much a topic of clinical research or translational research in atypical HUS. It's one of the big topics that the global registry is looking into. So yes, CNS involvement, but also other organ involvement, the involvement of other organ systems in atypical HUS outside the kidney is very much a research topic. Alternative strategies for the treatment, I need to be a little careful to not crossing lines of confidentiality. The answer is yes, there's a number of treatments in development. Published already are a C3 antibody, comstatin, which is interfering with the complement activation cascade one step up from where eculizumab works. There is a MASP inhibitor that's also published made by a company called Omeros. And I think all the others are so far in the stage at a level of development, and the details are probably more or less confidential. So I leave it at that. But there is development ongoing.
Okay, and then I'll just paste in the chat that other question from Cheryl, and please let us know if you're running short on time. We really appreciate you being with us here today, but I know you have probably a whole bunch of other things happening this morning. Cheryl's wondering, a person with CFH antibodies currently being treated with eculizumab is considering coming off. In that situation, is there any research showing eculizumab has fewer risks than receiving blood products or fewer infection risks than steroids?
Ooh. So if I may, I would like to rephrase the question a little bit, and I come back to the infection in the end, to the infection risk. So as I said, in patients with antibody-mediated HUS, there is alternative treatment strategies, which is using plasma exchange or immunosuppression to lower the antibody titers. And then at that point, for sure, it would be fair to make an attempt to discontinue eculizumab under continuous continued monitoring of the antibody titers and keep the patient on this immunosuppressant treatment strategy. That is what the literature suggests at the moment, and I think this is consensus of the worldwide expert community. So yes, there is a possibility to use a different strategy. The infection risk, I think it is negligible when it comes to eculizumab. There is, of course, always in theory an infection risk with blood products and plasma. If the patient went on plasma exchange or infusion treatment, exchange in this case, would in theory pose an infection risk, which is minimal, if blood products are used according to current standards, which make them extremely safe. So I don't think, in all honesty, with my professional insight, that at this point, the question about, or the concern about infection that might in theory come with the use of a blood product is not the determining factor or argument, to decide between one or the other treatment strategy.
Okay, thanks. Linda, did you want to share some more news from the aHUS Alliance perspective?
Yes, if you could put those slides.
I think you're still on mute. Yeah. Sure, come all slides, right?
Yes, please. It shows my microphone's working. Is it not?
Okay. Yeah, it's working. It's just maybe on a bit of a delay, but we can hear you. Hold on one second. And loading. Can you see those okay?
Those, if we could go back to the homepage of the aHUS Alliance in the presentation that I sent.
Your slides, not the ones from
please.
Kamal.
Correct.
Okay, sorry. Slides. There we go. And go back to the first slide of Linda's slides, right?
There we go. Thank you so much. I wanted to mention that thank you for that very robust and informative presentation on atypical HUS. And we do, in fact, have a lot of interesting items coming up with the aHUS Alliance. Rob, I am unable to advance my. That screen is missing. Thank you. One of the key things that the Alliance could do, and we've seen that in some of the questions that have been asked this morning, is the lack of information that patients have. So the Alliance is endeavoring to coordinate the information, to rather sweep all the information up in an information portal. And that's the new website that launched last month for the Alliance, aHUSallianceaction.org. As we collaborate with others, we've talked about research, we've talked about genetics, we've talked about clinicians, and all of these are aspects that roll into the Alliance mission statement. We want to amplify what is going on in each country. You had mentioned complement inhibitors and the development of those new investigational drugs that are in the pipeline for complement-mediated kidney diseases, which might in fact be of high interest to the atypical HUS community. When we look at the Alliance, one of the goals of a patient organization is to be an independent and objective voice so that we can present this information from a variety of research and investigational aspects and coordinate that so that we can promote global awareness of aHUS, but also especially, going to your point, to work with international aHUS researchers Part of that will be, as you've seen from different nations, there are different situations in each nation. In some cases, eculizumab is available, widely available in the US. It's available to more of a degree in European nations, but there are many countries that do not have access to treatment. So a goal with the Alliance is to support isolated patients who do not have a patient group, but also to work with newly emerging patient organizations. And I think Rare Connect, with its global webpage dedicated and specific to atypical HUS and available in 6 languages, supports that international dialogue. Because at the end of the day, all of us are working together in that communications flow to save lives and to improve the quality of patients who do have atypical HUS. One of those things, last year we initiated as an alliance in 2015, the first ever aHUS Awareness Day, which was global. We would expect to see this year many of the aspects from the 2016 Atypical HUS Global Poll come up in that information. Now, hopefully you will connect with us, all the different stakeholders, whether you're a person, a group, patient group, an organization, if you're in healthcare, physician, researcher, genetics, biopharmaceutical. We are interested in having all stakeholders put forth information of interest to the aHUS community. As an objective and an independent voice, our goal is to make sure that we can connect the information that's out there and give added value to everyone's message. So we hope that you connect with the Alliance on Twitter at aHUS Alliance. Also, we hope you participate in September 24th, Atypical HUS Awareness Day. This year, the campaign is Rising Above aHUS, which will mean different things to different nations. Our goal is to amplify each nation's messaging. And as a reminder, the Alliance is individual patients, caregivers, families, and supporters who are a dedicated force within their nation. It's nothing that we can do for you. We can amplify your nation's message. We can get your needs and concerns out there. So we hope that you include us in your tweets and social media. On aHUS Awareness Day, we are privileged each year to do aHUS awareness projects on Rare Disease Day, the last day of every February, in celebration of all those who strive to make better outpatient outcomes for rare disease patients. We anticipate that coming up, we will be creating more assets as an alliance. We'll be looking for all nations to volunteer once again, as we called out for volunteers for all aspects of the 2016 poll. We'll be calling out for volunteers to participate in engagement, making fact sheets, graphics, and some other assets available worldwide. But also we run a YouTube channel that has informational videos that are medically based on the aHUS clinical channel on YouTube. We'll try to keep posting anything that we find of interest to aHUS patients and caregivers, as well as medical personnel, regarding research, investigational drugs, clinical trial data, and we would encourage you to interface with the Alliance so that if there's a medical conference where a paper or a poster is going to be presented, to engage us and let us know, and we'll be happy to, again, amplify that messaging. We expect to delve deeper with the 2016 poll results so that we can provide additional insights, additional data, but also importantly, make that connection of putting the pieces together to show how the poll data and research can combine to give a more full picture. One of the things you can expect to see from the Alliance on aHUS Awareness Day and in materials and assets in between is information regarding the state of aHUS patients and dialysis. According to our poll results, the 2/3 of patients needed dialysis either during or after the initial onset, and only about 1/3 mentioned that there was no dialysis needed at all. You can see almost a third mentioned what came up in the other presentation of medical information is extrarenal involvement, the impact of atypical HUS on other organs of the body. Not surprisingly, more than a quarter report that there is an effect on their work or school quality. Issues with emotional aspects of the challenges of dealing with a chronic and rare disease. People reported at 27% of respondents reported that they had anxiety and depression. These are all things that we would expect to see coming up in aHUS Awareness Day messaging from individuals as well as from nations. An amazing amount of people wanted to participate in atypical HUS research. The catch is they weren't quite sure how. Almost a third of respondents responded that no, they don't know and they haven't, but they would like to know how. So I see that as an area that we can look at. We also heard about research going on, global research, international research. And one of the interesting things that came up in this study is there were a high number of respondents reported that their first episode of atypical HUS triggered during October through December. So there are opportunities for the patient community to interact with international research, either to provide data or provide information on potential areas for further research. Because some of the key things you can expect to see is the poll showed that atypical HUS treatment options varied greatly by country. Sometimes it even varies greatly within each country. It's dependent in some nations on the patient. Sometimes patients are have available the complement inhibitor eculizumab. I'd like to point out that 95% of rare diseases do not have any treatment. And so we are in the lucky 5% where we have one complement inhibitor already approved for patient use. And there are several biopharmaceuticals with investigational drugs that are in research and development in various clinical trial phases. Another thing that showed is that cost concerns are of an issue, showed up as an issue on the 2016 poll results. 7 out of 10 reported that either their specialist or their medical team mentioned cost of aHUS treatment when they were discussing patient care options. A quarter of respondents indicated that their atypical HUS medical care or treatment was limited by their national or health ministry policies. These are things that you can expect that the nations within the Alliance will be interested in exploring more in the coming months. There are different factors and considerations that might be of interest to people who with drugs in investigational or trial phases or even in clinical trials. One of those was that the cost of new drugs would be likely to affect their usage, and that was reported by almost a third of respondents in the poll. Over a quarter said they would be interested in hearing about that from their medical team, which again brings forth the issue of different stakeholders communicating, whether it's patient education, whether it's physician education, or just connecting the information in different ways. So communication flow is going to be very important. One of the things that was mentioned was access to drug was a key consideration in the 2016 polls. You can see in the difference in what happens to our chart. If you take a look over here to the left, you can see that a great number, 3/4 of people, said that yes, the complement inhibitor eculizumab was available in their country. But when you take a look at what happens to that number, if you exclude the American responses and the EU responses, I'll again remind you that there were a high percentage of American responses in the poll. But if you take a look to the right and you look at that orange section now, that's a very small, greatly reduced amount of people who have access to eculizumab throughout the world. So it's very much on the minds of nations within the aHUS Alliance, is making sure that all patients have expanded access to information, but also that medical care options and access to treatment is something that should be considered. And again, that would be different things with clinical trial directors, healthcare ministry. But again, it's connecting all these pieces of information together. So I would highly recommend that all people listening to this seminar, to anyone who is looking on social media to connect with any phase of aHUS information, engagement, whether it's working within one nation, working globally, please do connect with the aHUS Alliance. We're on social media. There is a Facebook page, the aHUS Alliance. We're on Twitter at aHUS Alliance Act, and aHUS Awareness Day is at aHUS 24 September. And we do encourage everyone to participate so that the messaging and the information gets connected moving forward. So whether you're an individual, an organization, industry, researcher, medical personnel, patient, caregiver, we invite you all to engage with the Alliance. And thank you again to Rare Connect for hosting this for the aHUS community. Special thanks, Dr. Licht, for the wonderful presentation that was rich with medical information, as well as your insights and commentary on the poll. And especially we want to thank the adult aHUS patients and pediatric caregivers who participated in creating the patient voice with the 2016 aHUS Global Poll. We have 15 nations already in the aHUS Alliance. If you are a person listening to this in a different country and you are not yet organized as a nation, we invite you to email us and start a discussion about how aHUS advocacy in your company can be supported and expanded, no matter how small. Everyone has a voice in their care and in being an atypical HUS advocate. And that will conclude my comments from the standpoint of the aHUS Alliance.